Hello, everyone. Welcome back to StatTech Research's seminar series on measuring progress and well-being. I'm Kelsey O'Connor, one of the organizers. Today we have Ekaterina Oparina, who will discuss well-being impacts of volunteering and exercise. Ekaterina will speak for around 40 minutes and then address questions at the end, at which time please raise your virtual hands or post your questions in the chat. During the presentation, please keep your microphones muted. And as a last reminder, we are recording the event. You'll be able to find this and past recordings on our website and YouTube channel. Now to introduce Dr. Ekaterina Oparina. She is a research economist at the Center for Economic Performance at the London School of Economics and a research affiliate at the Wellbeing Research Center at the University of Oxford. Her work focuses on mental health, subjective well-being, and the evaluation of public policies that aim to improve quality of life. She uses applied econometrics and large-scale administrative data to show how interventions such as psychological therapies, volunteering, or social prescribing affect mental health, social outcomes, and employment. Her research has been published in outlets like Scientific Reports and the Journal of Business and Economic Statistics, and she contributes to policy discussions through platforms like the IZA World of Labor. Ekaterina holds a PhD in economics and is committed to producing evidence to inform policies that contribute to a happier and better functioning society. Ekaterina is one of our young, let's say, junior scholars in well-being that you guys should all be paying attention to. If you didn't know, she contributed to the paper on that uses the median to respond to papers like Bond and Lang. So worth following in general. Without further ado, Katya, the floor is yours.
Thank you very much, Kelsey, for this very kind introduction. What I was saying is that I would want to talk about well-being impact of volunteering and exercise, and I'm happy to take questions as we go. And I already know which couple of slides I'm going to skip because of our slide technical glitch. Sorry about this. I would want to frame this talk in terms of social prescribing. And unfortunately, I couldn't fit social prescribing in the title of the talk because there is a lot of stuff there. But social prescribing was what motivated us to do this work to begin with. And social prescribing is the idea that health professionals can refer their patients to non-clinical services, which are often offered by local voluntary and community sectors. And interacting with those organizations would allow patients to improve their health and well-being through lifestyle interventions. Those could be healthy eating, time spent in nature, volunteering, doing sports, socializing in various ways. And the idea of this is not new. It refers to social determinants of health as opposed to thinking of health in its biomedical model. And it becomes particularly popular due to the growth of social isolation. Over 30 countries overall today have some sort of social prescribing programs, and they're usually presenting as this sort of win-win solution where the individual or the patient gets control of their healthcare because they can co-design and co-produce interventions. Health is treated as a part of lifestyle rather than something completely separate. And altogether, it's aimed to reduce healthcare costs because these patients would get improved healthcare outcomes, partially outside of healthcare system. And the amount of evidence, the literature on the effectiveness of this sort of interventions is growing. Here on the map, on the left side of the slide, you can see in blue those countries that have some sort of social prescribing policies. I will be largely talking about the UK and England in particular, so I want to give you an idea of how this works in England. The program was rolled out in 2019, and here it is a part of a primary care system. So general practitioners, primary care physicians, can refer a patient to a link worker if they believe that that patient can benefit from social prescribing. A link worker would have an interview with the person, identify personal needs, and direct them to a community service, whether they can interact, do these sort of activities like volunteering in sports. Francesca asked me a couple of weeks ago about the scope of that in England. I didn't quite had a good answer back then, but now I do. By October 2023, there were almost 3,500 social prescribing link workers working with general practitioners. And over 2.3 million patients have been seen since its rollout. To give you an idea of the scope, it's around 4% of English population. So this is non-trivial, but for example, talking therapies have seen over 7 million of people. So it is already of quite a scope, but this is still growing, and over 92% of primary care networks would have an access to social prescribing link worker, though primary care networks would include multiple GP services, and there would be a need for over 6,000 workers for each GP to have at least one. So this is a fast-growing but reasonably recently established sector. But an important part of it is that it relies, so the healthcare part of social prescribing links a person to the community service referrals. So the effectiveness of social prescribing interventions would depend heavily on how the community services how they can relate to these community services and engage with them. So this is what I'm going to be talking about in this talk. I'm going to talk about evaluation of two large-scale lifestyle intervention projects that focus on volunteering in one case and volunteering in sports in another case. And I'm going to talk about how they affect mental health and several other outcomes. So these projects are possible because we have two wonderful NGO partners. One is GoodGym, and I will talk more about what is it exactly they're doing. The evaluation of that program is a joint work with Maria Katafan and Chris Krekel. And another is NHS Care Volunteer Responders, run by our voluntary service. And the evaluation of that is joint work with Chris Krekel, Alison Bowler, and Alison Smith. So we surveyed participants of these services. We combine it with admin data on their participation, and we try to understand how their participation affects their mental health and social outcomes. How we fit with this in the literature. So there is a growing literature on effectiveness of social prescribing, as I mentioned. A part of it is a small-scale RCTs. Those that study effects in high control environments, so we can identify very precise effects, but we're not exactly sure what they're going to look like if we roll it out in larger scale. There is a larger literature that use observational data, and in that case, we cannot distinguish between correlation and causality. So it could be that happier people go and volunteer, or could be people who volunteer become happier. And there is a small number of studies that use quasi-experimental methods, and this is the literature we contribute to. One of the papers here is a paper by Chris Krekel, which is an evaluation of volunteer responders, their previous iteration during COVID. There is another literature that is related, but not the one we're going to be looking at directly today. It's a literature on how social prescribing works as a part of healthcare system. And as you can see there, the papers in that literature is very new because in England, this is a quite new concept within healthcare system. What we want to know more about is what works best in social prescribing, how much to do it, and how long do the effects last. To give you a preview of the results, we show that participation in this volunteering in sport combined activities reduces mental ill health with the effect sizes between 0.1 and 0.2 standard deviations. These are moderate, but in this context, we believe them to be sizable. We also see increases in trust of approximately 0.1 standard deviation. We see improved other social outcomes like belonging, connectedness, and loneliness. And we see that participating in pro-social activities make people more pro-social. So people who volunteer are more likely to declare that they would want to volunteer in the future. We know now that the dose matters. Effects both on mental health and on trust increase in the number of tasks. So the more tasks people do, the larger is the effect on the outcomes. And if for mental health, even few tasks already show significant effects, for social variables to be affected, it takes more tasks and more engagement. We also found that effects attenuate after participants stop participating. So it's not once and for all solution. If people stop engaging in these activities, the effects would attenuate, and in some estimates would go back to the mental health, and the social outcomes would go back to the baseline. We estimate benefit-cost ratio between 20 and 30. This is based on life satisfaction measures. And this is super conservative because that does not account for beneficiaries. So this is only looking at volunteers. So let me tell you more about how these two programs are set up. What GoodGym declares as the main idea is the following. We think that gyms are a waste of energy. There are many neglected tasks and people in our communities that need that energy. We want to bring these things together. So they started in 2008, and since then they have 25,000 volunteers in over 60 areas of the United Kingdom, who helped over 40,000 people with an enormous amount of tasks. The idea is that they combine fitness with community service. So their participants, whom they call good gymmers, can walk, run, or cycle to a local community organization or to an older person and help them with practical tasks. This could be weeding community garden or assembling your IKEA cupboard or changing light bulbs or activities like that. So to get engaged, participants sign up on the GoodGym website and they get allocated to a local group. Then from their profile, they can see a list of available tasks within their local area and the description of these tasks, when they're going to happen, how far it is from their postcode, what type of task that would be, how long it will take. And beneficiaries of these activities are those who work with organizations who work with local communities and older people. We know that in case of GoodGym, some link workers do refer participants to GoodGym activities. What we did to collect the data, our survey, we ran 3 waves of online survey between February 23 and March 24. We sampled around 3.6 thousand members. For whom we collect mental health, social outcomes, demographics, and their participation in sports and volunteering elsewhere. And we combine this with admin data on participation, so for every participant, we know the full history of the activities since they signed up, when they participated, how frequently, in which geographies. On the right-hand side of the slide, you see the email that we sent to the participants. So our identification strategy is rather straightforward. Left-hand side here is the outcome we're interested in, and I'll be showing standardized outcomes for you to be able to compare 2 projects easier. And then we control for a bunch of demographics, exogenous and endogenous. We control for wave and region fixed effects because we understand that there could be some specificities in particular areas. The key thing here is how we identify treatment. So here, treatment is defined as participation in at least 1 session. That would mean that anybody who participated ever would be considered treated. Anybody who had never participated would be considered non-treated. You might be suspecting that it would be not straightforward to interpret this as causal, and I completely agree. So it could be that some people who have better mental health are more likely to participate. In this identification, we cannot rule out some selection, but we are trying to approach causality as much as we can. So first, we control for participation in sports and volunteering elsewhere. To rule out, for example, the fact that healthier people are more likely to volunteer, but they're also more likely to report better mental health. We also do a robustness test with looking at a different treatment, non-treatment split, where we only use non-participants who did not participate for reasons which are broadly exogenous. So, for example, the weather was bad. The results stay broadly similar. So I will show you the results, but for this identification, I encourage you to interpret it with a grain of salt. So that was the first project. The second project is NHS Care Volunteer Responders. It was launched in 2023. And it was a successor to the NHS Volunteer Responders project that was launched during COVID-19. There are currently almost 50,000 volunteers. And since the start of the program, so including COVID program, they completed over 2.7 million tasks with over 250,000 people. And this program receives very good evaluations from healthcare providers. So 80% of healthcare providers who were surveyed say that the program improves patient care. And recipients also value the program, and 42% of those say that they visited the GP less often thanks to the support of volunteer responders. We are, however, interested how this program affects their volunteers. So the objectives of the program is to ensure a resilient pool of volunteers who can step up in case of emergency like COVID-19. Also to increase the capacity of healthcare system and to allow individuals to support their local healthcare systems through volunteering. How does it work for a volunteer? So volunteers sign up and pass a security check. They have to download GoodGym app, and if you've never heard of the GoodGym app, I really encourage you to go on their website. They're absolutely fantastic. There is a great amount of applications of this app, so this is one of them. Volunteers install the GoodGym app, switch to on duty, and then if there is a task nearby, they are alerted. Tasks can be things like delivering prescription or grocery to somebody who is isolating or who cannot get them on their own, checking in chat, which is calling people and asking how they're doing, but also in more recent iterations, ambulance support and discharge support. So if as a volunteer, I get an alert, the one you can see on the right of the screen, I can either accept it, reject it, or let it time out. So if I do not respond within 15 minutes, the task will time out and go to the next volunteer. Here we also did an online survey, and the baseline survey is still in the field. So this is when participants sign up, they fill in the form. We did 3 quarterly surveys and 2 annual surveys, though the latest one, we haven't processed it yet, so I'm only going to be showing you the results up to October 23, up to January 24. We surveyed 11,000 people, and again, we collect mental health outcomes, some demographics, and combine it with admin data on participation. In both projects, we had a hope of creating a panel. That was the reason of repeated surveys, but unfortunately, we don't have enough variation within person to create a panel. So we're gonna use this as cross-sectional data controlling for wave fixed effects. Here, our identification strategy is way closer to causality. And the reason we can do that is first because of oversubscription. So the way the program is designed is that they would want to have more volunteers than tasks, because this sort of micro-volunteering depends heavily on individual availability. And so that everybody is available at some moment in time, there is an oversubscription by design. And then when the task is allocated, and if it's a local task, so prescription delivery, for example, the app will choose a person who is geographically the closest to the task. And then if that person cannot do it, it would move next and next to the person. So this allocation for local task is random, conditional being within 25 kilometer radius. And for tasks like check and chat, it's random altogether because there is no need to be in a particular geography. And here, the same as in the previous one, we want to look at how intensity matters and how time since last treatment matters. So we're going to modify this, and instead of treatment dummy, we're going to have a bunch of dummies for intensity, so number of sessions and how much time passed since the last time. Our preferred treatment specification would be treatment is 1 if a person was allocated, accepted, and completed the task, and 0 if the person was not allocated a task or task timed out. We got some feedback that people are a bit worried about task timed out. So possibly we're going to move to the main specification as not allocated the task yet, because it's cleaner and because the results are very similar. I saw a question, but it disappeared before I could read it, and I'm not quite sure where to find it. So,
Question for me, Ekaterina, but
hi,
please,
Francesca.
I mean, let me know if you prefer to be interrupted during the presentation or if you
Yes, I'm
prefer to
happy to be
collect.
interrupted. Yeah,
Okay.
please go ahead.
So my question is, this is very fascinating, but a quick clarifying question is, what kind of administrative data do you have, and how did you manage to link them to your surveys?
So all participants are registered with their emails, and surveys were conducted through the partners. So the partners could link the data that we collect from the survey with, because they send it to these emails. So they send surveys to the emails that are in their database. Then people fill in the surveys. They merge it on their side, remove all individual identifiers, and give us the data, final data set with no emails or other identifiers. So this is why we can link through emails. And in terms of what sort of data we have, we know the activities that they perform. So what sort of tasks, at which dates, in which, and we know the characteristics of this task. So the location of the task, how long it took.
Very
Does that
interesting.
answer?
Yeah.
Yeah.
Very
Good.
fascinating. Thank you.
Good. Thank you.
Ekaterina, so same sort of, when I think administrative, this is government data on the tasks that are being undertaken. And so the government is collecting this information before and after surveys. So, and it's not on a select sample. So they have the full universe of residents in England. Is that correct?
This is not a government data. This is the data that's held. Let me move back to the. So this is the data that's held by these two organizations. So GoodGym holds the data on their participants, because to be a participant in GoodGym, one needs to register with them. NHS Care Volunteer Responders holds the data on their participants. And because we both work with both of them directly, they can kindly share our survey with their participants and then give us the data.
Mm-hmm. So the control
yeah,
group is always among people who have already registered to these two organizations, or one of either, depending on which.
Absolutely.
Okay.
Yes.
Thank you.
So there's going to be two different analyses, and the surveys always would involve people who are registered for this. We think that it can be interpreted as an advantage, because the idea of social prescribing is that you cannot really force people into social prescribing. So people who would at least consider participation are probably the same people who registered. And then whether they do or do not participate is a different question. But understanding the effect of social prescribing on the people who would never self-select into social prescribing might be useful in a very limited way.
And as of now, we cannot answer that question. So we don't know how it scales to people who have to be encouraged by, say, a link worker to sign up. It's only including people who voluntarily sign up for these organizations.
Yeah, so these are people who signed up for GoodGym. There would be link workers directing people, but again, link workers can signpost, but they cannot mandate.
Okay.
So these are all only on the people who signed up for the end. I don't have it in the slide deck for the sake of saving some time, but these are, as you can imagine, non-representative of the UK population.
Okay.
So they are slightly younger, slightly richer, slightly more female. So yeah, this is just a quick comparison, because I understand I'm throwing a lot of information at you. So we're looking at two projects. GoodGym combines sports and volunteering, which can be done individually and in groups. We had 3 waves. We collect mental health and social outcomes, and we compare those who participated with those who did not participate, but all of these people signed up. And as Robinson's checks, we compare with those who did not participate for exogenous reason. NHS Care volunteer responders does micro-volunteering, which is individual, in person, or on the phone, if we're talking about check and chat. We have around 5 ways of the survey. 1 is still in progress. That would make it 6. We collect mental health, though through slightly different measures. Trust and future prosociality. We also collect other social outcomes, but they only show up in the annual survey, so I'm not going to show it until we complete the processing of the last annual survey. And here it's a cleaner causal strategy. We compare those who completed the task with those who were not allocated a task or a task timed out, and we have that group because there is oversubscription. So let's move to the results. I'm going to show you a set of results for GoodGym and some key takes away from there, show you a set of results for volunteer respondents, and we'll see that they are broadly similar, despite the fact that these are 2 rather different projects with rather different identification strategy. So this is a baseline result for mental health. Here it's measured by GHQ-12. And the first column only has control for wave fixed effects and the effect of 0.3 standard deviation. As I've mentioned, hard to interpret causally without any other controls. So we add controls for exogenous and endogenous controls, as well as controls for doing sports and volunteering elsewhere. That reduces the coefficient, but by around 25%, and puts it to around 0.2 of standard deviation.
And Katya, just for those who are unaware,
Yeah.
the GHQ-12 is the Generalized Health Questionnaire or General Health Questionnaire. It's a measure of mental health, right? And so higher scores means lower mental health. Is that correct?
Yes, thank you very much for clarification. Yes, so here we would want to see reduction in GHQ because it's the higher levels would mean worse mental health. Here is a set of results for our secondary outcomes that include questions on loneliness, belonging, connectedness, and trust. And I'm only going to show you the results with all controls. So the final column from the previous slide. We show the effects to be between 0.1 and 0.3 standard deviations, which are sizable in this context. So people feel less lonely, and they feel that they belong to local community more, they feel more connected, and they feel more trust. Here, I understand we're testing for a bunch of outcomes. So we also control for multiple hypothesis testing. So at the very bottom, you can see Riemann-Wolf p-values. So all these results survive multiple hypothesis testing check. So it's unlikely that we find these results just by accident because we tested a bunch of hypotheses. There is some heterogeneity. Younger people seem to benefit more. Women and lower income people benefit more for some outcomes. I'm not going to move there right now, but happy to take a question on that if anybody is interested in heterogeneity in particular. In terms of intensive margin, so yeah.
Sorry to interrupt you, Ekaterina. It's again me,
Please.
Francesco.
Francesco.
Actually, I was curious to know. This is the effect on those that volunteer, basically.
Yes.
You do not include in the survey those that the effect on those who received who benefit from the action, do you?
That is a very good point. We don't include beneficiaries at all. We don't quite know how to do it. So if you have a good suggestion, that would be wonderful. So we have people who benefited. We can survey them, but well, probably they would report some benefits. We don't have any control group because it's hard to match these people with similar people who were not helped. So if you have any ideas, please do let us know, because it would be great to include beneficiaries here or in the other project.
No, I don't have any clear idea at this moment, but it's safe to say that then if the benefit of these actions on the society are likely larger than those that you're estimating, because you're only looking at part of those who will actually benefit, so the volunteers.
Yes, we are. Yes, that's true. Yes.
So it's a kind of a lower boundary, if you want, of the benefit.
Very.
Yeah.
It's like it's the effects of volunteering is sort of a side effects of what is usually thought of what's beneficial from volunteering. Yeah.
Thank you.
All right. So I'll move to the number of tasks. So here on the right, you can see effects. We split all the respondents into 4 groups, 4 quartiles by the number of tasks that they performed. And you see that for GHQ, even 4 or less tasks already show some effect, but it's not the case for social outcomes. So social outcomes take more tasks to be affected. In general, we can see that the effect increases in the number of tasks, though with decreasing speed. So you see this concave effect in GHQ and belonging, for example. In terms of persistence, when people stop participating, the effects would attenuate. And for GHQ and loneliness, there's still some effect in 6 months past the last time, though the effect is smaller. For belonging, connectedness, and trust, this effect, the effect goes all the way to 0, so the individual's responses would go back to their base level. So it doesn't look like these effects change something fundamentally, but as long as people keep volunteering, they keep getting the effect. They stop volunteering, the mental health and social outcomes attenuate sometimes back to 0. So the key takes away from here are both mental health and social outcomes are affected. More tasks lead to better outcomes. Even few tasks affect mental health, but not social outcomes. And these effects attenuate over time, with mental health still affected 6 months past last task, but not social outcomes.
Katya, is that
Yes.
a moment to ask a difficult question on the result here?
Please do.
So somebody who's more trusting might be somebody who undertakes more tasks. That's part of what your results show, but interpreted in the opposite direction. And so there's a dose effect, as you've said. And your main control in this is if somebody participates in sports or volunteering elsewhere, right?
Yeah.
So the control is a little bit like related to dose. So this is doing additional sports and volunteering. You have an additional effect on trust. But it could be the other way around, that more trusting people are doing additional volunteering in sports. Would that be fair?
So if the basic idea of the question is that we should interpret this as causation cautiously, yes, I completely agree. So that is the fact that so in this case the base specification can be interpreted as causal cautiously for the reasons you just mentioned. And yes, we see that our attempts to control for things that can bias the result do not change the result, which is good, which means that if there is self-selection, it's not enormous. But generally, yes, we know that people decide on the number of tasks that they do. And it could be that those people who, for some reason, have done 200 tasks compared to people who did no tasks, that self-selection would be stronger. But I will show you the results of another study now, where the causal identification of the treatment effect is stronger, and the patterns will be very similar. Though I still take the comment that people select how many tasks they do themselves. So it could be that just people who do 200 tasks are systematically different in some ways that we don't observe.
Thank you. Sorry to give you a difficult question.
Oh, no, fair enough. I will move to the second set of results, which is NHS care volunteer responders. I hope you are watching it in a large screen because I'm going to have enormous tables here. I apologize for that. We're going to look at mental health index, which is columns 5 and 6, which is a combination of PHQ-2 and GAD-2. PHQ-2 is a standardized questionnaire to measure symptoms of depression, a very short version. The usual one is much longer. GAD-2 is a shorter version of GAD-7, which is a questionnaire to measure symptoms of anxiety. Here, outcomes are also standardized. Mental health index is just a combination of the two. So we see a reduction in symptoms of mental ill health of those who volunteered compared to those who were not given a task or task timed out. So here the treatment identification is way closer to causal interpretation because we're comparing people who did the task with those who did not have an opportunity to do the task. And it looks like the result for depression is slightly stronger, but with this precision, it's very hard to say. What we can say is that mental ill health is reduced by 0.15 of standard deviation. Here is again about the number of tasks. And as in the, so here columns 1, 3, and 5 in all these tables are the modals without individual controls. Columns 2, 4, and 6 are modals with individual controls. So I'm largely going to be speaking about columns 2, 4, and 6, and here mostly about column 6 because this is where the combined mental health index happens. As in the previous exercise, we see that the effects get larger in the number of tasks, though as Kelsey have alluded, it could be that these are just systematically different people in the way that we cannot capture. And as you can see, the number of tasks here is very different. So here we go from 1 to 10 tasks. In GoodGym, we're going up to 200 tasks. So we are in different parts of the distribution of the number of tasks, but it looks like the pattern holds. The more tasks, the larger is the difference. In terms of persistence, we again see that effects go down to 0. So if you look here at column 6, those who just did a task 2 days ago have an effect of 0.2 standard deviations. Those who completed their last tasks over 160 days ago would have a way smaller estimated effect, which is indistinguishable from 0. So if in the previous exercise we did not see effects attenuating in 6 months, here we do see effects attenuating for mental health within 160 days. In terms of trust, we also see positive effect around 0.1 of standard deviation. We do routinely this step down p-value to check if the results we find are just because we're testing too many hypotheses, and it looks like that is not the case. Couple of more of enormous tables. This is dose and persistence for trust. So this is the number of tasks for trust. And again, the more tasks one would do, the higher is the effect. And for trust, effects disappear even earlier. Within 2 months, we already do not find any statistically significant effect. I want to show you one result that we've done in annual survey, even though we haven't processed the last wave, because we find it particularly interesting. So we asked participants to say whether they are planning to volunteer in the future and how many tasks they are planning to do. And those who volunteered, compared to those who were not given a task, said that they're more likely to volunteer and more likely to do more tasks. We interpret it as an idea that pro-sociality creates more pro-sociality. Getting exposed to volunteering gives people more motivation to continue doing it. So the key takeaway, yes?
That's great. I like that one a lot. Does this one attenuate? Do you know?
We haven't checked because we have 2.4 million observation, but I'm making a note that when we have both, when we process the final this year's survey, we hopefully will be able to check it. Yeah, that is a very good question, which I unfortunately don't have an answer at the moment.
Thanks.
Sorry, let me
Yes,
allow me to step in one more time.
please.
Basically, you're showing that the effects of the treatment in some cases are not very persistent over time, and I'm not really familiar with mental health measures. I don't know if, for instance, if depression can vary quickly in half a year, but when it comes to trust, my experience suggests that trust takes time to build and can be easily destroyed, but it takes time to build. And what you're showing here is that basically, if I do volunteer yesterday or up to 20 days before, that there will still be a positive impact on my trusting in others. But if I
So
volunteered like 2, 3 months ago, then there is no statistical effect on my trust. Like if I had lost or got back to my baseline of trust, how do you
yeah,
interpret this?
yeah. So there are two things. First, these results agree with your statement that trust takes time to build. So people with one task, we see effect at 10% significance. Somehow I cannot. I'm not sure if you can see my cursor, but it's this second column of the first table. So people who only completed one task have some effect, but with high standard error. So it's significant to 10%. The effect gets larger and way more precisely estimated with the number of tasks. So we also see that it takes some time to build trust, unlike mental health. So our mental health measures are also super light touch. So these are not diagnostic criteria. This is not people moving above or below the threshold of clinically diagnosable depression. This is people responding to quite light touch measures of mental health. But here, trust takes time to build. And then these 2 days are not, so it could be that you completed 10 tasks and your last task was 2 days ago. So here we don't know how many tasks one completed, but we see that indeed if it's been 2 months since your last task, then all the gains in trust from participating in volunteering would disappear.
Interesting. And did you consider doing interaction between the dose and persistence?
We have it's asking a bit too much from our sample, but when we get the final survey, we will, let me note that down. We will try to do that. Persistence with time, with dose. It would be interesting to know. Now with this number of observation, it's hard, and unfortunately, this program will stop at the end of May, so we're not going to be able to get any more data, which is well, the program closing is unfortunate, and us not being able to get any more data on it is just a small part of how unfortunate it is that the program does not
This is a
exist.
more general question that perhaps does not pertain the specific moment of the presentation, but in general, I'd be curious to know why does a program that works would be shut down? Lack of funds, or I mean, in the end, we are UK is perhaps saving some money on the healthcare sector.
Yeah, so there are quite seismic changes in the UK healthcare sector at the moment. So this is a part of those changes.
I'll stop interrupting you. Sorry.
No problem. No problem at all.
Tiny clarifier. Is trust measured here 0, 10 or binary 0, 1?
It's definitely
similar?
not binary. It's
Okay.
definitely not binary. It's a Likert scale, either 0, 8 or 0, 10. Probably 0, 10.
Okay, that gives us more
But yeah,
variation.
Yes, this is not a binary, None of these measures, apart from future participation, is a binary. So the only participation is here, yes, no, in likelihood. So
You had a
mhm.
sorry, you have a question from Chiara. If you want to unmute yourself, and then maybe we should be brief. I realize now as we're running low on time. But thanks. Okay.
Yeah, thank you guys, and thank you, Katya, for your presentation. It's very interesting, and I do apologize if my question, if I missed something, because in the beginning you discussed about these link workers, who, if I understand correctly, are the one that assign people to or encourage people to be part of this program. But are these the people that are actually treated in your study? Or the volunteers are completely different individuals?
So some of these volunteers were directed through link workers, possibly. So we know that link workers refer people to the GoodGym, but we don't know whether. So we don't have a marker for each individual how they appeared in the program. So they would come in and register, and they are not typically asked, "Are you here because the link worker referred?" It would be interesting to know, to understand how the effect might differ depending on how people arrived. But yeah, unfortunately, we don't know that.
Yeah, a second question, more a remark, that it would really be interesting to know what is the effect on indeed on the people that are participating to this say to this experiment, because and in that case I think it could be interesting also to control for the state of the provision of healthcare in specific areas, because we know that in the UK health service, healthcare is stretched, especially psychiatric service. There is very little accessibilities in certain areas, and I'm not sure whether a local area fixed effect would entirely be able to capture that. Thanks.
Yeah, thank you, Chiara. Yes, so I guess it's a slightly broader question than the one we are taking on. So how these activities affect local area outcomes. This is so from studying social prescribing as a part of healthcare. This is a definitely very important question. Here we are sort of answering only a part of it, looking at how people are affected, but whether that moves the needle on the outcomes for local areas. Yeah, we cannot say that within this scope, I'm afraid. Thank you.
Katya,
I have few minutes.
We have well, another question in the chat, which we can come back to at the end if it's better for you, and we can go a couple of minutes over if that's fine for those who are attending and yourself, of course. So.
Yeah, I'm happy to go a couple of minutes over. I'm reasonably close to conclusion. I wanted to show you cost-benefit analysis, but we don't need to spend a lot of time on that. So as we've already discussed, we don't have any data on beneficiaries. So we use life satisfaction effects, and we use UK Treasury evaluation of Wellbeing, where one Wellbeing is 1 point on life satisfaction scale. For one individual for 1 year on a scale of 0 to 10. And we calculate for a GoodGym benefits cost ratio of 20. So benefits are 20 times higher than expenditures, not considering beneficiaries. And we have a number of 30 for NHS care volunteer responders. I wouldn't necessarily interpret it as one is 50% higher than another, because these are both super conservative estimates. I think the best way to read this as both are very, very cost effective. And that takes me to conclusion. So we evaluated 2 real life examples, and we think that it's important that it's real life, because these are people who are willing to participate in this sort of activities, and social prescribing relies on people willing to participate. We show that this participation is effective in improving mental health and social outcomes. For mental health, even few tasks help. Trust and other social outcomes take longer to be affected. Impacts are increasing in the number of tasks, though following Kelsey's comments, concerns about causality in this finding. After participants stop participating, the effect is attenuated faster for social outcome than for mental health. And here we are more certain about causality because one of our identification can be interpreted causally, and people cannot choose when they stop to participate if they haven't been allocated a task. Volunteering increases probability of, or at least declared probability of volunteering in the future and the number of tasks people are willing to do. And benefits far outweigh the costs, even in our very conservative estimates. And for some miraculous reason, I finished on time. But let me take the question from the chat, which doesn't have to be the final. I'm happy to answer more questions. Could it be that the effect on trust is not coming from volunteering itself, but from the fact that they were given a task? It could be. It could be. Then it would be surprising to see effects across both programs to be similar, because in the GoodGym, people choose to do a task rather than being given a task. And so generally it's hard to distinguish whether it's because they were given a task, and then if they were given more tasks than otherwise, that would make them more trusting, and if they haven't been given a task for a very long time, that made them less trusting. So I guess, strictly speaking, one can interpret it this way, but it would be surprising to see similar effects across both slightly different approaches, because GoodGym doesn't have this task allocation mechanism.
Thanks. Actually, that makes a lot of sense. Katja, can you go back to the dose, maybe on, and also actually the cost-benefit analysis, you have life satisfaction, but we were primarily studying mental health. Did you compare, how did you do benefits in life satisfaction terms? Yeah.
I didn't show you the results for life satisfaction, but I do have them. So if interested, working papers would have all of them. We sort of focus this as mental health sociality thing, but because we are all well-being researchers, we always ask and run life satisfaction regressions. So if interested, happy to share when we put it all together.
Can you compare the magnitudes, again, maybe on trust from the last intervention, the NHS care? Show us the figure again. I'm thinking about the dose effect and comparing them. So, okay. So we have, in the case of trust, you go from, you basically have almost a doubling, let's say, going from one task to
10 tasks.
To 10 tasks. And so that's pretty meaningful. Also, I think that in your first example with the GoodGym, because you're controlling for whether or not people contribute to sports or volunteering externally, you're getting a dose effect. You're going from some contribution to more contribution, or some to more volunteering, more. Do you understand what I'm trying to say?
So I wouldn't say them, because some of them will not be volunteering or doing sports elsewhere. Yes, I control it away. So independent of whether people are doing sports and volunteering elsewhere, just participating here would give these sort of effects. The magnitude, well, the number of tasks are very different. So there we went from 1 to 10. Here we go from 4 to 200, because this is a longer program. So we have people who serially participate in there. Yeah. But so I appreciate your suggestion that we can interpret it as a lower bound, but I think in the trade-off of trying to make it more causal and use it as a lower bound versus moving further from causality and having something higher. I'd probably think the conservative option is safer.
Yeah, it's just a interpretation. That's fine. Please feel
Yeah.
free, anybody in the audience, if you would like to ask a question, either to write in the chat or to raise your hand. We're after the time now, but we could stay a couple of minutes. In the meantime,
I'm
I'll ask
also
another question.
gonna
Go
leave
ahead.
this in case somebody would come up with
Yeah.
some burning questions after we finish. Here are my details. Please drop me an email. Yeah, Kelsey?
The cost ratios. So this is something that I think that you're quite familiar with. Can you compare it with another program? So is this, and I take your point that this is a lower bound, so maybe we shouldn't be comparing, but maybe you can give us an example of the small scale RCTs, what kind of effect size they have, and or this compared to some other intervention, just to give us some idea of efficiency, relative interventions between interventions.
These are enormous. These cost-benefit ratio are enormous. So when we do NHS talking therapies, our cost-benefit is something like 6 on mental health. Because so I think the key here is that the costs are so low that benefits, even this moderate to frankly low magnitude benefits, would give very high cost benefit ratio, because the cost estimates for one person is I think £60 in one case and £55 in another case, because these are very large scale efficiently run programs, and these are enormous. These cost benefit ratios are enormous.
The effect size then may be larger on the talk therapy or RCTs, but the costs are very different.
Yes, the effect sizes are larger. Yes, but the costs would be in way higher than 60 pounds per person. Yeah, because this is a clinical interaction. There would be 7 sessions and a large NHS machine running. Yeah.
Nikos, feel free to unmute yourself. You can ask.
Yes. Hello, Ekaterina. Thank you very much. Amazing presentation and really nice data. Once again, about the intensive margin of GoodGym, you have the sports and volunteering, and you say that it is individual or group. And the question is, do you check for differences based on individual sports or group sports, or individuals or being an individual or in a group sport?
Yes, thanks, Nikos. This is a very good question. We would want it. So the first thing we try to do is distinguish between the effects of volunteering and the effect of sport, which is sort of slightly earlier than your question, because there would be some activities that include more sports and less volunteering, and some activities that include more volunteering and less sports. Yes. It's very hard to distinguish because the line of observation here is a person, and the person could have done 200 tasks. And then we went into a person for whom at least 50% of tasks were with at least 50% of sports. And then that rabbit hole didn't really lead us anywhere, because it's very hard to find so in terms of group versus individual sports, so there would be group runs and people running in circles or working in community garden. There would be individual tasks when it's it's a person on their own running to for example, old person's home and collecting and helping them to put together their wardrobe. So I guess what we can do is split by the type of tasks and then look at the share of each individual of a particular sort of tasks. Maybe we're going to have more luck there. Thank you. We'll try to find in the data where there is anything that we can. Another heterogeneity we would want to check for, and we're hoping we can get the data, is some of these are in green spaces and some of them are not. And there is seasonal demand for green spaces, indoor versus outdoor. So it looks like it matters for people. But so far, we don't know for each task whether it's, so that is another heterogeneity we are hoping to be able to look at.
Okay, nice. Thank you.
Thank you.
We have a question from Julia.
Hi, Katya. I don't know if anyone has their cameras on, but I'll turn it on just because I feel weird talking to no one. So,
I could.
Hi. Oh, thanks.
Mine
Good.
was off because my internet was suboptimal, but
that's okay. I have a few curiosities questions, but we don't need to all stay here unless people are interested. I had one question specifically on your experiments, and that's quite simply, I have an idea of what the mechanism would be, but do you have any way of testing how volunteering affects mental health?
Oh, please tell me what's the hypothesis.
Can you test it, whether it is purpose or meaning? Do you have any purpose or meaning questions in your, because I think the GHQ has one of them, but I can't remember. I forget the 12 questions. But then if you did on life satisfaction, you could see whether volunteering has an effect on life satisfaction because of purpose or meaning.
We have life satisfaction and purpose. We tried running a specification where we included, so we had GHQ as a dependent variable and all loneliness, belonging, connectedness, trust. Did we include life satisfaction and purpose there? I'm not sure. With these four, for sure, there is still some effect not explained by the channels.
Right,
possibly, okay. If we include purpose and life satisfaction, that would change. I should be able to check. Thank you.
Thanks. And then again, if there's no one else that wants to ask questions, I have an opinion question, which is less related to your paper per se, but on social prescribing. And it starts from the question of, when does social prescribing happen? How does a GP decide to give social prescribing rather than meds, or being referred to some other sort of specialist? What's the condition with which someone goes to the GP and it gets referred to social prescribing?
I'm probably not the best person to ask, because that's not exactly my field of study. My understanding is that it does not necessarily go instead of medical treatment. It can go together with medical treatment. So the formal instruction is that if the GP identifies social needs, and then if they identify social needs, they refer it to the link worker, where the link worker would further find a way to satisfy the social needs in the best way. But how that works exactly, it's hard for me to say, because I've never studied that in details.
Yeah, okay, thanks. No, my question is more general, or to anyone in the audience who has an opinion on this, is how many people are actually going to go with the social prescribing, both in terms of GPs and patients. Maybe, the more traditional sort of medicine reference is something that people are more comfortable with, and they might think, oh, this is maybe useless. Why am I even doing this if I have a hard condition, if you will? So it's more on a question of social prescribing than it is on your paper. So opinion related.
Yeah, I'd assume there would be a large variation, as there are large variations, and with also there is regional variation with availability of link workers, and there would be other variations with the way link workers are used, because this is a new program and it takes time to establish.
Sorry, one last. I didn't hear your answer to Chiara when she asked about the linked workers. Can you test in your data set how many people are enrolling in these programs because of linked workers? You said that earlier. I just missed the answer.
No, unfortunately, we cannot. We know that people are referred by link workers to GoodGym, but we don't know in our sample how people appeared.
Yeah. Okay. Thanks. I'm done. Thanks.
Thank you.
An implication of this line of questioning actually is that the costs are for the whole program, whereas the benefits are only among people who are doing a take-up, right? So it's actually, if you can improve take-up, you'd actually improve the even further, right? You would improve
I'm
the
not
cost-benefit ratio even further.
Sure, the cost. So these are costs per volunteer, because we have benefits per volunteer. So we take all costs and divide them by number of volunteers. So if you can double the amount of volunteers without changing the costs, this would halve. But it's hard to imagine that. So probably there is a part of fixed costs, but there would be some additional per volunteer costs. But generally, scale would probably help.
I guess what I'm thinking, the link workers is what we're missing, I guess. So the link workers are not part of the costs, but they're small. I think you have a small number of link workers, as I understood. So this seems like incredible stuff for places like Luxembourg and everywhere else to implement, those 30 plus countries. Very good. Thank you. Interesting. We are now quite a bit after 6 o'clock Luxembourg time. So I think we can close it there, unless, Katja, you have any final words for us?
No, thank you very much. Thank you for great questions. I've made quite a few notes. Hope to be able to share a working paper with you in due time.